director, we have some chief residents. We have some chief residents here. So it's definitely going to be an amazing session. And to keep up with the tradition of CP solvers, we would, pass mic to all the program leadership and all the residents and ask them to share a brief thing about their program, brief thing about their introduction, and what is their favorite food item. Because at CP solvers, we love to consume the food. And it's always nice to know that what are the favorite delicacies from Maryland, from the state which they are representing. So maybe first I would ask Dr. Asim Sood to tell us a little bit about himself and what are the favorite food that he likes.
Hi there, good afternoon. Thank you for joining us on behalf of University of Maryland Midtown Campus. My name is Asim Sood. I'm an internal medicine physician. I work in the Department of Medicine here as a hospitalist and serve on the faculty at the School of Medicine. I did my residency training and chief residency here in this program. And I would say as a Marylander, my favorite food is crab cake. With that, I will pass off to our program director, Dr. Davin Chow, next to me.
Thank you. I'm honored to serve as the program director for the University of Maryland Medical Center Midtown Campus Internal Medicine and Transitional Year program. We're based here in Baltimore. It's a small program. We have 9 residents each year, but we're closely affiliated and linked with the University of Maryland Medical Center at the downtown campus. We're less than a mile away from the medical center and the medical school. We have a wonderful group of residents here, very proud of them. And I'll pass the baton over to Khalud. Oh, I'm supposed to mention about
favorite food.
All right, so look,
Yes,
we don't even need to discuss this, all right? So it's crab cakes. I mean, I've lived in Baltimore for 30 years, and people ask me, why do I live in Baltimore so long? And you can't get good crab cakes anywhere else. I've tried. I've tried. Even Washington D.C. they have crab cakes. In Philadelphia they have crab cakes, but there's nothing like a Baltimore crab cake. So come to Baltimore, have a crab cake, see for yourself. But the challenge is, if you want to start a fight in Baltimore, you ask people where to get the best crab cake.
Yes, that's a contentious subject.
Oh, it can cause riots because people are very passionate about where to get a crab cake.
Wow.
I'll leave it at that.
Hey everyone, I'm Khulud. I'm one of the PGY3 chief residents. I'm super excited to be here. A little bit more about me. I'm an aspiring endocrinologist / diabetologist. And then if I had to choose a favorite food, I don't know, I feel like everyone's gonna be mad if I don't mention crab cakes, but beyond crab cakes, I would probably have to mention maybe Indian food, lamb biryanis. I love that, but yeah.
Hi everyone, my name is Fahad. I'm a PGY2 in this program. I'm originally from Bahrain. A little bit about me is I'm, I guess, aiming to go into cardiology. In terms of my favorite food, I know the push is for crab cakes, but there's a really nice waffle place close by.
Hey, there we go. A little outside the
A
box.
little bit of diversity in terms of food.
Something sweet.
Something sweet. Throw a little chicken as well. It's nice.
Hi, everyone. I'm Sneha Thomas. I'm also a PGY2 categorical resident. Interested in vascular medicine. And in terms of my food, kind of had to agree with the Khulud. Instead of lamb biryani, I would say chicken biryani is my favorite. But I'm from Philly as well, so I'd have to say cheesesteak.
There we go. A little colorful addition on Sneha. We're all learning something about Dr. Sneha.
Sure. I mean, just like your program, your choices are also very diverse. And I have to agree with Dr. Fawad that a little bit of sweetness is always appreciated. And personally, I am also from a land of Gujarat, which is also known for its sweets. So excited to hear that. And maybe now, before we jump into the case, I would like to introduce all of my fellow colleagues because without them, this won't be possible. And usually Dr. Rabi Jia used to facilitate, but probably he's running a little bit late today. And we are sure that he will join us soon. But before that, I would like to pass mic to Rafa, our dear team member, to introduce himself. Please, Rafa, tell us about yourself.
Hi, everyone. So my name is Rafael, and I'm a last year medical student from Brazil. And I guess my favorite food here in Brazil would be brigadeiro, which is a very sweet, and very good. You guys should definitely taste it. So now I'll pass the mic to Maria.
Hi, thank you so much. My name is Maria. I'm from Guatemala, and I'll keep it going so we don't lose any precious time from you and your program. Vale, do you want to introduce yourself?
Yeah, hello everyone. I'm Vale from Lima, Peru, and I'm scribing today. So really excited for the case you have, and an honor to have you join us.
Franco, do you want to say a quick hi?
Hi everybody, I'm Franco. I'm calling from Lima, Peru, and my favorite food is Peruvian ceviche. I have to pass the mic to Tiago.
Hi, my name is my name is Thiago. I'm a Brazilian physician, and I agree with Rafael that brigadeiro is the best from Brazil, and also barbecue. So I love barbecue as well. And I'll pass it on to Sukriti.
Hi guys, I'm Sukriti. I'm one of the PGY ones in Michigan. I'm really excited to hear our case today.
So now I would ask Dr. Bukhari to please start presenting the case, and I would ask Valeria, who is scribing, to bring the whiteboard, and then we would jump in.
Good morning, everybody. Look at this. I'm so sorry to interrupt your flow.
Yeah, no worries. Welcome, Dr. Jia.
I feel like we're just about to jump into the case, and I'm thrilled to see everybody hopping on. I just wanted to apologize. I am not here to the rescue. I don't need to rescue anybody. I unfortunately got pulled into an emergency coverage situation in the emergency room. 2 emergencies there, but I wanted to say hi and thank you all for joining us today. I see the MTC team room 1 ready to jump in and present to us, and just wanted to thank you all for taking the time on a Saturday to be here, and a special shout out to the CP Solvers team who jumped in to cover me covering, which is the ultimate gift. So thank you all. I'll be hanging out peripherally and listening to the case, and hope you guys have a ton of fun. Thank you.
All right, thank you everyone for this lovely introduction. So I'm going to start with a problem representation. So a 50-year-old male with poorly controlled diabetes presents with acute onset of upper gastrointestinal symptoms and is admitted with diabetic ketoacidosis and is found to have severe hypercalcemia. So moving on to the chief complaint, he presented with nausea, vomiting, and epigastric pain for 1 week, and a detailed history of presenting illness. It's a 50-year-old male who presented to the emergency department with complaints of nausea, vomiting, and epigastric pain for 1 week. His emesis was non-bloody, non-bilious, and occurred 5 to 6 times per day. His epigastric pain was dull and continuous with no radiation. He also complained of fatigue, increased thirst, as well as increased urination. He has a history of insulin-dependent diabetes mellitus, and he ran out of insulin 2 days prior to the commencement of his symptoms. And a little about the pertinent review of systems. So he did not complain of any constipation, no flank pain, no bone pain, no weight loss, no confusion.
Sure.
And then moving on to the past medical history, he has insulin-dependent diabetes mellitus. He was diagnosed at the age of 43 when he was admitted to the hospital with diabetic ketoacidosis. He was discharged on a regimen of multiple daily injections of insulin. Follow-up testing showed normal fasting insulin and C-peptide levels. Autoantibodies were ordered at the time, but testing was not completed. He was later transitioned off insulin 3 months later and was started on metformin. He stayed off insulin for several years and was controlled with oral anti-diabetic medications only. He restarted insulin 3 years prior to his presentation.
And it seems like there's a question. Does anyone have any thoughts here?
Yes, I mean, just I want to clarify one thing, Dr. Bukhari, that you told us that the patient has hypercalcemia, right? Elevated calcium.
Hypo.
So severe hypercalcemia, so elevated calcium levels.
Sure. And do you think this is a good place to stop and discuss something before you give us a little bit of more data?
Okay.
Yeah, sure. Yes, so I am sure that it was going to be a challenging case, and it sure seems like that from the HPI that we have got. But whenever we approach a problem, as we have learned from our CP Solvers team members, that we have to understand the base date of the disease, and we have to understand that if the symptoms that we are having, are they representative of the underlying cause, that is the diabetes itself, or is it something new? So if you just take away the hypercalcemia for a little bit and you focus on the 50-year-old male presenting with the complaint of abdominal symptoms, a little bit of nausea and vomiting, and the first thing that we have to consider is whether we are dealing with ketoacidosis or whether we are dealing with hyperglycemic, hyperosmolar coma kind of thing. So checking the sugar level is something that we should be aware of. And we know that in patients with diabetes, if you end up getting acidosis, then that will trigger the metabolic acidosis cascade, and that would result in end organ dysfunction, abdominal pain, and all other symptoms. So we have to be aware of that. But Dr. Bukhari specifically mentioned that it was severe hypercalcemia, which again points us that what if hypercalcemia indeed is playing a little bit of role in symptoms. So thinking about the hypercalcemia, we know that hypercalcemia can also present as abdominal pain. It can cause ileus, it can cause constipation, and maybe that's why patient is having nausea and vomiting. That is why we have to be aware of the fact that what can cause hypercalcemia. What are some of the common causes of hypercalcemia? Maybe we can start by ordering PTH, vitamin D levels, phosphorus levels, inorganic calcium levels, and then maybe we can move ahead. So that is the one framework that we have to be aware of. And apart from that, let's see what else we have. Yes, I think deciding between the hypercalcemia and hyperglycemia as the chief contributor to symptom is something that we should be aware of. And now maybe I can pass mic to Maria to share her thoughts that what are we missing? What should we focus more on, Maria?
Yeah, awesome. I feel like you have the right question. Is it a primary calcium problem or is it a primary glucose problem with calcium complications? And I think Kelly Mesa in the chat has some thoughts on the calcium. I don't know if you want to share them out loud and introduce yourself. Or Kelly, are you? Yeah, awesome.
Can you hear me?
Yeah.
Yeah, we can hear you now.
Okay, so because the age, I was thinking like primary hyperparathyroidism, maybe because the age. But it's important to know also the family history because most of primary so I think it's important too. But also, like as you mentioned, diabetes can also. If we had to know how was the pressure to know the volume, because in volume depletion, then we have high risk of hypercalcemia. So it's important to know how was the blood pressure and the volume status of it.
Blood pressure and volume status. Thank you for those points.
And since we have beautiful endocrinologist, our dear Thiago in the house, maybe we can ask him to share his thoughts because it definitely seems like an endocrinology case. And I'm sure that Dr. Bukhari also wants to be endocrinologist in the future. So we knew that it was going to be endocrinology. So Dr. Thiago, please enlighten us that what are your thoughts at this point?
Thank you, Krita. Actually, I'm not this good, but here the first thing that comes to my mind, is it ionized calcium or not? Because acidosis, it causes the release of calcium from albumin. And so the ionized calcium is expected to be high. The opposite if you are hyperventilating. So people who are hyperventilating, the calcium binds to albumin and then they have like a hypocalcemia. It's not a hypocalcemia because the total calcium is normal, but that's the reason they can feel like really bad, then can feel like everything's tingling or whatever. So the first thing here is it ionized calcium or total calcium? And also, besides this effect on albumin, the acidosis increase calcium influx from bone. So it generally happens with chronic acidosis, not something like DKA, but it's important to note that if you have acidosis, then you can expect total calcium to be high due to this increased efflux of calcium from bone. So first thing I will do here is to confirm that it's total calcium elevated, and then for sure I would follow the path suggested here that is to check for PTH that Kelly suggested. But first of all, knowing if it's ionized total and how it is related to the acidosis, I would also like to know if the acidosis was corrected after correcting the DKA, because some patients, they have DKA and they have like a renal failure and they have acidosis regardless of the DKA, and so it can explain the hypercalcemia as well. So I would follow this path.
Thank you so much, Thiago, for those insights. And maybe then I can pass the mask to Rafa very quickly to share his thoughts before we move on to the next aliquot.
Oh, no, I love the thoughts that you guys are having right now, and I have nothing to add. So please carry on.
Yes, sure. So Dr. Bukhari, we are good to go, and you can give us a little bit more data.
Sure. So in terms of his drug history, he was on metformin 500 milligrams twice daily, as well as insulin glargine 27 units twice daily. In terms of his family history, he did have a history of family history of diabetes in his paternal grandmother, as well as his aunt. He also had his father also had a history of prostate cancer. In terms of his social history, he was an ex-smoker. He quit more than 20 years ago. He does not drink alcohol or use any illicit drugs. Mm-hmm. And then in terms of the physical exam, his temperature was 36.2, his heart rate was 130, his blood pressure was 87/47, his respiratory rate was 18, and his stats were 100% on room air. He was ill appearing, he had dry mucous membranes, cardiovascular as well as respiratory exams were pretty unremarkable. And in terms of his abdominal exam, he had no tenderness, no guarding, no rigidity, no organomegaly, and he had a negative Murphy sign. In terms of neurologic exam as well, he was oriented to time, place, and person. He had no focal neurologic deficits. Mm-hmm. Should I go into the labs? So his initial labs showed a white cell count of 24.7, hemoglobin of 19, and a platelet count of 169. And then in terms of his chemical profile, he had a sodium of 127, potassium of 3.8. His CO2 was 20, chloride was 80. His anion gap was 27. His BUN was 32. His creatinine was 1.8. His glucose was 425. And then he had an albumin of 4.7, total protein of 8, bilirubin of 2, AST of 21, ALT of 24, and an ALP of 121. His calcium was 17.3 milligrams per deciliter. Unfortunately, we only got an ionized calcium several days later, but that was elevated as well. His lactate was at 2.3. His A1C was 11.1%.
We have some questions from the chat, it seems. I will catch us up a little bit that it seems like Anne Marie mentioned she would bear in mind that phosphate levels may be affected by DKA as well. And Dr. Tiago mentioned that it's very important in children. They need to have phosphate replaced. And also DKA resolution is warranted before better understanding this calcium profile. The DKA itself can increase calcium and decrease phosphate. And others in the chat suggest hemoconcentration may be involved here. And someone mentions they'd be curious about past labs for a baseline, as well as 17 is very high for hemoconcentration, Dr. Ravi Singh adds. Additional process taking place, it seems. And Dr. Tiago asks a total calcium of 17.3, correct?
Correct. Mm-hmm.
Sure. Thank you so much for clarifying that, Dr. Sood. And are we in a good place to stop and reflect, Dr. Bukhari, or can we go ahead? Yeah, sure. We can discuss. All right. So now we have a little bit of more data. We can see that the patient vitals are something alarming. The patient is in a shock. And as we discussed in the first record, that if it is indeed diabetic ketoacidosis, then we would assume that the patient can get hemodynamically unstable. And although the temperature is not higher, but we have to be aware of the fact that diabetes is one of those conditions that can predispose you to infection. And shock can present in this manner because sometimes shock can cause hypothermia rather than hyperthermia. So infection is something we should always be aware of. And always in patients with diabetes, if there is some sort of exacerbation, then infection is usually the key. Infection is something which drives you off the chart. So we have to be aware of that. And another important thing that initially we were discussing that how high are the calcium. Now 17 is something which is very, very high. And usually symptomatic hypercalcemia occurs when calcium goes above the 13. So I think we are dealing with something very sinister. And usually this much degree of hypercalcemia is associated with hypercalcemia of malignancy. So definitely I agree with Dr. Thiago, Dr. Ravi, Dr. Kushal and all who shared their thoughts in the chat that it's wise to get PTH, PTH-RP, that is parathyroid hormone related peptide. It would be wise to check the 25 hydroxyvitamin D levels as well. And along with that 125 dihydroxyvitamin D levels, because sometimes lymphoma and all those conditions which can have granulomas can have that enzyme 1-alpha hydroxylase, and that can lead to hypercalcemia. So definitely we would want that. Maybe later on in the course, we can even go for CT scan of the abdomen and pelvis to make sure we are not missing any solid tumors. And now before I keep on rambling, I think Anne-Marie Comfort has some amazing thoughts in the chat, and she is also our beloved team member and kind of leader for us. So Anne-Marie, if you are in a place to unmute, please share your thoughts.
And Marie,
Yeah.
you're muted.
Sorry. Hey everyone, I'm just getting over an illness, so hopefully my thoughts aren't too jumbled today. But we were just looking at the labs, and obviously there's a lot of really striking abnormalities here. I think my question here, the first thing I would do is to see if I have recent labs to compare to get like a baseline, because obviously there is a lot of volume loss in heme concentration here, but it's difficult to know what degree that is playing here. So I'd be really interested to know kind of the baseline hemoglobin, if there was one from prior hospitalization, to know if polycythemia was present before, and to also see the effect after giving really aggressive volume repletion. And I'm also wondering if the patient is going to be thrombocytopenic after getting volume repletion as well, kind of considering how high the albumin level is and how the other labs look, if maybe we're going to be to the point where we have a really high hemoglobin and like thrombocytopenia. So those were just kind of some initial thoughts, and I'd be curious how much of an effect the DK versus the hypercalcemia is playing a role on like the volume status. So I'd definitely be interested in past labs and also seeing the effect after volume repletion, because I think that would help guide the workup a little bit as to what might be going on.
Sure.
Thank you for
so
sharing
much.
that.
Yeah, sure. And before we move ahead, I wanted to mention one quick part, which actually I learned from CP Solvers only a few months ago, that whenever we have polyuria, like excessive dehydration is there, then what are the things that we consider? So we consider diabetes mellitus and diabetes insipidus at top of our differential list. And in diabetes insipidus, we have to worry about nephrogenic cause and central cause. And in the acquired nephrogenic diabetes insipidus cause, we have to understand that hypercalcemia and hypokalemia are those two electrolyte abnormalities which can, temporarily shut down the ADH receptors and can lead to excessive wasting. So I guess in our case, the patient is in shock, the patient is dehydrated, as evidenced from the dry mucous membranes. So we have to understand that apart from hyperglycemia, hypercalcemia also may be contributing to dehydration because 17 is too much. So that's why we are dealing with this complex pathology. So those were my thoughts. And now Dr. Bukhari, please give us some more data.
Sure. So we had a few more labs that came back at that point. His PTH was 5 with normal levels being between 8 and 54. His PTHRP was, or parathyroid hormone related protein, was less than 2. And then his 25 hydroxy vitamin D was 10 with normal levels being from 20 to 80. And his 125 hydroxy vitamin D was 17.3 with normal ranges being from 19.9 to 79.3. We also had a few more labs at that point. So his glutamic acid decarboxylase was greater than 250, with normal range being from 0 to 5, and his islet cell antibodies were 1 to 16, with normal being less than 1 to 4. And then we also had his urinary calcium, which was greater than 17.8. Additional workup was done, including protein electrophoresis, which showed no evidence of monoclonal protein. And then he had computed tomographic scans of the chest, abdomen, and pelvis with contrast, which showed no evidence of malignancy.
Maybe we can pause there.
Is this a good place to stop, Dr. Bukhari?
I think so. Would you like to dissect that a little?
Yeah, sure. So just to clarify, the PTH levels were also within the normal range, right?
So PTH was 5 with normal revenue. So it was suppressed. Normal is 8 to 54.
Sure. All right. Okay. So I guess we have a lot of data. And first I would just reflect on glutamic acid, those antibodies, and then I would pass mic to Maria to share an amazing schema on how to approach the hypercalcemia in such situations. So those antibodies definitely raise the suspicion that what if we are dealing with, either type 1 diabetes or something which Dr. Anne Mary mentioned earlier in the chat, LADA, that is latency associated diabetes of adulthood. So both of those are possibilities. And now maybe Maria, can you share that schema so that we can, dwell further into how to approach this hypercalcemia?
Yeah, awesome. So I'm gonna share my my screen on what we've been talking through the hour. So we had hypercalcemia, and it was actually very severe. So that pulled us away from hemoconcentration or a secondary process, and that was actually, the gravitational pull came with the severity. So always when you consider electrolytes or abnormalities in your labs, as they get more severe or more abnormal, that's going to pull you more towards thinking of a primary calcium process and not, as we were first thinking, that it might be secondary. And so the first breaking branch in the schema is PTH. And so in here, we do know that the PTH is normal and it's actually suppressed. So even like normal levels can make you think, even if it's like in the normal range, would make you think that the PTH is abnormally elevated, but in this case, it's suppressed. So we do know that it's independent of the PTH process. And so we have all of these different causes. And so we do know it's not dependent on the PTH-RP because that was also negative, and that indicates mostly malignancies. And as they did, there was no evidence of malignancy in the scan, so we can put that lower in our diagnosis. And so, for example, now we need to focus. I don't remember the vitamin D levels, but I think it was normal, right?
Yeah, go ahead.
So 25 hydroxyvitamin D was actually low at 10, and 125 hydroxyvitamin D was also slightly low. So not elevated. Both were not elevated.
Okay, that's useful because then we know that it's not dependent on PTH, it's not dependent on PTH-RP, and it's also not dependent on vitamin D. And so we need to think about the causes that we tend to forget. So for example, lytic bone disease, and go back and check for the medications. And so Kushal actually mentioned early on about TUMS, which have a great calcium percentage. And I think this part of the schema, the lytic bone disease, the other, which is meds or endocrine abnormalities, is where we're at. And I'm eager to see how we move in the schema with more information.
So I just want to to put one important thing here. So we are leading to an esoteric cause of hypercalcemia. It's not common at all. The most common cause being primary hyperpara, which is not the cause here. And just to call the attention that thyrotoxicosis can cause hypercalcemia, and it also triggers DKA because it increases the resistance to insulin action. So I think it's important to check her thyroid function tests because There is diabetes here. It's autoimmune diabetes, which is a risk factor for Graves' disease, and also Graves' disease will trigger DKA and could cause hypercalcemia. Just to make a point about this connection. And you know, I'm not saying it's Graves' disease because we are very far from having this diagnosis, but it's something to keep in mind.
Yes. Thank you so much, Mary and Thiago, for sharing your thoughts. And I agree with you that once we have one endocrine pathology, we have to understand that we are dealing with, you know, cascade of underlying pathologies. Like what if patient has adrenal insufficiency, because that can also cause shock, that can also cause hyponatremia. We don't have hyperkalemia here, so that is, you know, kind of away from it. But again, if you are nausea and vomiting, then that can kind of, you know, compensate for the hyperkalemia that you would expect with adrenal insufficiency. So I guess all of them are fair point. But one of the things again that, you know, kind of stumping us is the severe degree of hypercalcemia, because as you told us that when we have hypercalcemia which is so high, then usually all other minor causes like, you know, hydrochlorothiazide, vitamin A intoxication, usually they don't tend to cause this degree of hypercalcemia, and usually malignancy is the underlying cause, but we don't have any signature of that here. So it's definitely an, you know, stumping case. So please, Dr. Bukhari, teach us that how we should approach further and what were your thoughts while you were dealing with this case.
Sure. So let me just I guess give you guys my last aliquot. So he was initially admitted to the intensive care unit for management of DKA. His anion gap closed on day 2 of admission, and he was bridged to subcutaneous insulin. He received aggressive intravenous hydration with isotonic saline, and he also received intravenous zoledronic acid. His calcium levels improved to 8.6 milligrams per deciliter on day 5, and he was discharged home. During a follow-up visit with endocrinology, he admitted to ingesting large amounts of over-the-counter calcium carbonate or Tums to help with dyspepsia.
Okay, that makes a lot of sense. You know, it's always wise to get back to the ground zero, you know, to encounter the patients, to ask them that what were the medications we were taking. And this is another humble reminder that how we often tend to miss all these medications. And, you know, before we open the chat to the questions regarding your program and the virtues of the program, maybe I would ask very quickly to Thiago one last time to share his thoughts that how common is this thing, and have you ever encountered this before in your practice, Thiago?
No, I've never seen a milk alcohol syndrome. I'm glad that I've seen here virtually. Thank you for sharing this case. It's not common at all because, you know, most people that take calcium, they will not have like high calcium. They will have a low PTH and everything will regulate, and then you get a normal calcium. So I've never seen it, and it's incredible, you know, because you would expect bicarbonate to be high, but he has DKA at the same time, so it changes everything. So, and you know, as I said, I've never seen, and glad to see it, and an opportunity to study it again and again. Thank you.
All right, then once again, thank you, Dr. Sood, Dr. Chow, Dr. Bukhari, Dr. Fawad, and I'm sorry, I forgot your name.
Dr. Sneha.
Dr. Sneha, yeah, Dr. Sneha, thank you for bringing us amazing case. We learned a lot, and again, a humble reminder that medications are always a vital part. We should not miss it. We should keep on probing it deep as long as we don't get the answers. So thanks for that. And you know, before we open the chat to the question, maybe I can ask one question if you don't mind. So is it all right if I ask one question regarding your program?
Please.
Sure. So we have seen that University of Maryland Midtown Campus is, you know, an amazing place because it is affiliated with the downtown campus, and both of those programs are very kind of nicely knitted with each other, and the residents are also very friendly. So I wanted to ask maybe all of you that what is the one thing about Maryland Midtown Campus which, you know, keeps you running all the time, which keeps you inspiring, which keeps you give motivation?
Good question. Good question. You're going to see a lot of thinking faces for a moment here.
Yes.
Well, Dr. Chow, would you like to go first, or would you like to delegate that answer first to anyone?
I would say it's our patients. I think we deal with a very challenging group of patients who kind of like similar to kind of the case that we discussed about getting a history. You know, there are many challenges that are faced by this population. I think that kind of puts us in check every day. I had a patient yesterday who came in with like ischemic leg, who was lost to follow-up for several weeks. And instead of kind of saying like, oh, why were you lost to follow? Why did you not follow up with whoever you're supposed to? When we were kind of digging into the history, we just found out the patient's wife passed away 3 weeks ago. And he had prior history of stroke, has expressive aphasia, multiple complications, no social support at home, lives by themselves, by himself. So who is supposed to take care of, you can kind of say from a medical standpoint, you can be like, oh, you didn't follow up, you didn't do the things that you're supposed to do, or you can kind of go in that track, but if you kind of back off and try to understand the situation, you can't really place the blame on the situation, I think that's kind of, I would say our patience is definitely a big aspect of what kind of keeps us in check and challenged on a daily basis.
That's a great answer.
Yeah, I would
Please.
have to agree with Sneha. I mean, I think residency here teaches you a lot of empathy, a lot of compassion. But in terms of what I think the best thing about the program is, I mean, while it may be a cliche answer, I think that it's the fact that it's like a small community program with affiliation to a large academic program as well. I think that sort of gives a family feel to the program. You know everyone, you pretty much know all of the faculty from the very beginning. You're appointed a mentor, you sort of, find yourself going down that, that career track that you sort of foresee for yourself. So you get all the support that you need while also sort of being in this like small, very warm family-like place. So I think that's probably one thing that I really enjoy about the program.
I should give an answer.
Dr. Fahad?
I think the family feel is important, but at the same time, like I think I've enjoyed working with all of the attendings here, recognizing that Dr. Sood is amongst us as well.
They can't be completely honest because I'm sitting here.
But even as we have all the consult services that we need here, but at the same time, I've seen in a lot of other institutions where seeing that this is primarily internal medicine program where once we consult the service, hands off, let them decide. Whereas here, a lot of the attendings actually push you to understand what's happening, why is it happening. Like they encourage you to try to think of a plan and then run it by the consult service and see what they say. And the consult service here, especially like endo, cardiology, neuro, they really want you to learn. And they can easily see a patient drop a note and then move on. But a lot of them typically want to have a conversation with you about what your thoughts are, what are the learning points you can get from this experience as well. And I keep having that on a daily basis, so I'm enjoying this, honestly.
Oh, thank you very much, Dr. Fahad, for kind words. We will pay Dr. Fahad after this.
I was going to just add, going back to the family feel, we can say that in front of Dr. Sood and Dr. Chow because we talk about this on a daily basis and we are not really scared of them, that we kind of have to keep our thoughts to ourselves. So I think it's fair.
If I have a complaint in this program or an issue I can deal with, I can easily email Dr. Chow or Dr. Sood. And I've done that multiple times before, and I've come to their office and be like, something happened. I'm not happy with that. Please help, And there was always a lot of support of this. I know Dr. Sood's smiling because he knows what I'm talking about. But that's the thing, right? No program is perfect. But the idea is that if there's something that you're not happy with, there's always that safe environment where you can talk to either the attendings or the program director, or even in a resident forum. Everything can be said at that time, and there's no other. I don't think the chief residents join the forum, right?
No.
So even the chief residents aren't there. So that whenever those complaints or those issues come across, they come across as if it's a problem that we're all having. There's no judgment. Why did you say this or why did you say that?
Yes, I personally think that we should stop this session and we should only hear to you guys because it's such we can feel that family vibes, conversation is going on and on. So thank you again so much for those honest experiences. And maybe, from all our team members, maybe I can ask one common question to Dr. Chow. Sorry to put you on the spot, Dr. Chow, but I wanted to ask you that you have such an amazing group of residents, amazing group of hospitalists who work with you day in and day out. And how it feels like to handle all of them apart from your all other responsibilities. It must be a challenging experience, but still you are doing it so enthusiastically. So how you do it?
Great question for the boss. How does the boss do it? Dr. Chow wears many, many hats here. He is also chairman of medicine, He's also past governor of American College of Physicians. He's very involved with a lot of different things. So I have the same question, actually. I'm not sure how he does it all.
Well, I don't, so our philosophy has been, I want this to be a resident-run program. I want to feel like the residents have responsibility for making sure the program's going in the right direction. We want them to have a stake in what initiatives we pursue. So I'm more sitting in the back of the bus, and I want the residents to be driving the bus. And for me, that's a lot more fun. I can look out the window, look at the scenery. For all programs, you can't do everything, and you have to pick and choose what you want to, what areas you want to pursue, what initiatives you want to seek out. And so we really listen. We need the residents to be part of that process. So I'll give you, for example, Dr. Sood last week, he ran a point of care ultrasound curriculum, and it was a very well thought, organized program. Well, first of all, the residents wanted ultrasound. We had to purchase the ultrasound, which was not cheap.
Yeah, not cheap. Ultrasound's expensive. We found out.
We were eating peanut butter and jelly sandwiches for a while there. But we did get a couple ultrasound devices for the floor, in addition to the one we have up in the ICU. And now we have this course, and now we're on this journey of getting the residents trained and familiar with using ultrasound. I think it's a great tool, and it's a curriculum that was really not my area of interest, not my skill area, but it's an area that I'm so happy that we're pursuing.
And I want to thank Dr. Kaluch. She's done a lot of work on that point of care ultrasound. And I would just add that Dr. Chow allows us to correct the course and to improve in this program. I have been here for longer than I imagine now. And I had a choice of where to take a job after training, like we all do. And I chose to stay here because I did feel like things that need to improve, we are trying actively to improve upon. And at least we have an open mind about things that I graduated this program not exactly confident in point of care ultrasound. And that's why we have a new curriculum this year the chief residents have worked really hard on. And we're trying to learn together. It is not that we have all the answers, but I do feel Dr. Chow and the program facilitate. Resident Forum allows a private space for people to talk. And I was involved in that in training. And I think these channels allow for us to be better than we were in years past. That's why I like to work here.
Wow, I think Kushal just mentioned, I feel like doing residency again for POCUS training. But more than that, I feel like you've opened your doors to us. And I think it's palpable, the family and friendship that you share with one another. And I think Dr. Chow's leadership really came through with his answer and with all of the residents here. It takes a lot of people to run a program, and relying on others is strength and really speaks a lot about the confidence and trust he has on all of you. And I really feel very thankful for having you here and you being so honest with all of us. And I wanted to ask maybe the chief resident here, just so that we can hear a little bit more about her. Who do you think thrives in this program?
So I think really anyone that comes here would thrive. I mean, we have residents that come in here with different career goals. Some people go into, pursue fellowship training. Some people come in with, with the goal of becoming primary care physicians or hospitalists. We also have transitional year residents who move on to sort of different types of specialty training, be it radiology or ophthalmology or whatever. And I think they all would agree that it's such a supportive environment here at the program, that you're able to sort of whatever your career goals are, whatever you're working towards, whatever it is that you want to accomplish, you're gonna find all the resources, the mentors, the faculty, the tools, everything that you need to sort of be able to accomplish that goal. And we've had people go into, some people go into private practice. We've had people go into fellowships, like doing various things like critical care medicine, cardiology, endocrinology. So I feel like really this is a place where everyone can thrive, just because you get that individually sort of tailored attention to help you accomplish whatever your goals really are.
And just to add to that, I think a lot of applicants, especially when I applied for a program, one of the first questions they ask you is what do you want to do in 5 years? And sometimes it's difficult because you don't know the answer. So I think what I've seen here and especially with other residents, is that even if you don't know what you want, the program really tries its best to try to get you to experience the different specialties, and then be like, hey, it's normal to change your mind. If you wanted to go into GI and then a year later figured out maybe it's not for you, primary care is an option as well. There's a mentor you can talk to, and then I think that's one of the nice things about this program, is you don't feel pressure to stick to the thing that you wanted to do initially. You understand that people change their minds. I would have thought that I wanted to do critical care, but then when I tried it, I realized maybe not for me.
So you decided on cardiology instead?
Oh, yes, outpatient cardiologist.
No, it's true. I mean, what Fahad says is right, because actually, for my own example, I wasn't exactly sure, and I know we have a very diverse audience here. I'll say that I think one of the points of pride I take in the program, I know Dr. Chow takes in the program, is the diverse cross-section of applicants we have and residents we have here from all different training backgrounds, US graduates, international medical graduates, and there's a harmony amongst the even transitional years. We have some transitional years who are going into ophthalmology, for example, and other specialties. There's a cohesiveness and a lack of pressure, because I didn't know what specialty I wanted. And I was laughing when Dr. Fahad said that, because there's a phenomenon some of you in the audience might be familiar with, where by the end of internship, most medicine interns have a phase where they want to do critical care. Because I felt that in our internship, almost all of us by the end, we all were going to be intensivists, because the thrill and the rush, there's an exhilarating aspect to your first time in the ICU as a medical trainee. It's kind of what you imagine in the movies. And then over the next years of training, some of us change our minds. And I think the thing I will mention is I feel the program does a good job of respecting people's origin stories. We have residents who trained with me who had prior experience in their home country of being a practicing physician. And some of us, like a young Dr. Sood, no clinical experience before residency. And with those different starting points and different competencies, I think we have I could see a scenario where it's difficult. People are at different starting places. But I think the residents generally get along, and we benefit from that diversity. There's some questions in the chat, I think.
Yeah.
Yes, Jasimran, please, if you can unmute yourself and ask the question.
Yeah, sure. Good morning, everyone. Thank you for joining us. So my question is, apart from the final board exam, how would you evaluate your residents on yearly basis? And if the program feels after some evaluation that one of the resident is not learning enough, like he's not up to the mark of that level of training, so how would you intervene?
Maybe I'll take that one. I think evaluation around the country is done pretty in a similar fashion. At most programs, you're as an intern, you're evaluated by the resident with whom you work, and also by the attendings with whom you work each month. They should give you face-to-face feedback. They also have to submit a written evaluation. And then at the 6-month mark, you meet with the program director or a designee of the program director, and they review those evaluations. I have to say, we don't do it well. We don't do it well. The evaluations that are done are not critical in nature. They tend to be more complementary than critical. And I've tried to get at the root of this. I've tried to address this. We've had workshops for faculty on how to give feedback. We've told them they need to give more critical feedback. But it's been a challenge. Part of it is that it's a small program. Everyone knows each other, including the faculty. You'll get to know the faculty on a personal basis, and maybe that's part of the challenge. But I think it's very important that residents get good critical feedback. There's a standard that we want everyone to meet. And it's not set by a program, it's set by the ACGME. It's fairly achievable. Most of our residents can achieve that standard, not break a sweat. And so most of the time our feedback is complimentary. You'll say you're meeting the standard, but residents aren't satisfied with that. They want to be achieving at a higher level. And it's our responsibility to help them meet them where they are. So it's a good question. It remains a challenge for us and a challenge for around the country.
Thank you.
Yeah, Dr. Chow, I just wanted to thank you for your honesty. It's very refreshing, and I think it shows, again, your leadership skills and how you're actively trying. And like you, as you said, it's a small program, and with those things, I think that the detail orientation that people have is very close to home. So it shows how much you care for your residents, and it shows how much you want to improve things for them. So thank you so much for sharing that honest answer. And I think we have more questions in the chat. I don't know, Varun, do you want to unmute yourself and ask your question?
Good afternoon, Dr. Chow. It's a pleasure to be here. I want to go into primary care after my residency. So I was actually keen to know how your program supports residents who want to go to primary care.
Well, I love primary care. I do primary care.
Dr. Chow's a primary care physician himself these days.
And I would love to see more residents go into primary care. I think it's a wonderful specialty. Part of it is the experience that residents get in the ambulatory setting, and particularly in the resident continuity practice. I think in general around the country, the resident continuity practices are challenging. You see a challenging population of patients, and trying to establish continuity while residents are busy doing other different rotations, and maintaining that continuity is also a challenge. We're fortunate in the last batch of graduates, 3 people went into primary care. And we have a new clinic medical director. We are moving into we have a new ambulatory building here, and in the top floor, the 10th floor of the new building is all going to be primary care. And the University of Maryland has traditionally been very much a subspecialty oriented institution, but it's realized that we need to do better primary care, have a focus on it. And so we're going to be hiring more primary care providers, making that top floor a centerpiece for ambulatory practice and guide care of patients with chronic disease in our community.
Thank you so much, Dr. Chow.
And I guess now, since we are nearing the end of time, maybe Franco can ask one last question and then we can wrap it up. Franco, please unmute yourself and ask the question.
First of all, I love the case, and I wanted to ask the question regarding here at CP Solvers, we love to use clinical reasoning as a tool, as a diagnosis tool, as something that we can improve our practice. So is there any protected time for residents to develop UI projects or meta research projects, especially that emphasize clinical reasoning, like the focus one?
So I think there's definitely opportunities to develop whatever projects you may be interested in. So you gave an example about clinical reasoning. So we actually have clinical reasoning conferences that we hold once a month. We started this actually last year, so at the beginning of my PGY2 year. So this actually started out as an idea really that I sort of discussed with Dr. Chow as well as our chief residents at the time. So I have this really long commute to work. That's about an hour or so, and I usually listen to the clinical problem solvers during that time.
Hey.
So we had these case conferences that were really not interactive, not engaging. Residents were probably sleeping at the back, and I wanted to change that experience for our residents. So I sort of just did some reading, came up with a proposal, and I shared it with the program leadership, and they were really excited about it. And they were like, okay, let's go ahead, let's give this a shot. And, we've been going for a 1.5 years strong, and it's been great. So they're really open to any ideas, any thoughts, any, whatever sort of initiatives that you may have. The program is very open and very welcoming for that. And then you also mentioned QI projects. So, I mean, we've had this focus, like the point of care ultrasound curriculum. We've had this, it's been going on for years, really. I think with Dr. Sood and multiple other residents who've been trying to develop that program. And so me and another bunch of other residents also had the opportunity to sort of jump in, come up with ideas, propose it to the, send a proposal to program leadership. And it's really, I think right now it's kind of my QI project. I just sent out a questionnaire to residents a few weeks ago just to get their feedback and sort of see where we stand in terms of that, of the POCUS project. So really there's a lot of room. Whatever ideas you have, they're very happy to hear them. They're very happy to implement them. As long as it's, I guess, within reason, but you'll find that this program is very supportive.
Yeah, and each year we have like two weeks dedicated just for QI project, a 2 weeks block scheduled for QI project as itself. So first year you'll get 2 weeks, second year you'll get 2 weeks, third year.
I think they do some QI time, and by third year, it's a graduation requirement that all the medicine trainees present their QI project. That I think is facilitated with the quality department, Dr. Chow and other leaders. But it's a chance to spotlight what they've been working on. And like Dr. Bakari mentioned, actually, a lot of these have kind of existed in longitudinal fashion throughout 10 plus years. And as residents leave the program, they often hand off to one of their juniors who's going to work on, hand hygiene or other aspects of hospital care that we've been tracking for a long time. So in that way, we do have a sense of continuity, I think, for the ultrasound thing that Khalud has worked on this year. I mean, we worked on in my time in its infancy. And so I'm happy that usually there's spirited chief residents each year who have the willpower and horsepower to carry forward some of those things.
Yeah, and even for like tech savvy people, there are people like one of our residents, Jay, worked on like a insulin, like an app that can kind of help you with deciding on how many like inpatient management of diabetes. So even for tech savvy people who want to develop your own apps, there's all opportunities for that. And I think even the changing the timing of the QI project to 2 weeks each year rather than like as a block. I think that was something that was worked on over the past few years as well, because when you first come in first year, if you have 1 month, you're still trying to figure out what exactly the project that you want to do. You're trying to figure out yourself, what you want to do with your life, project do you want to do. So
survive your internship, survive your internship also. Deal with being yelled at by me on an intermittent basis. The residents go through a lot. So yeah, I think it's important to break it up into pieces at each year of training.
Right. So you can have the continuity and you can work on it throughout. Yeah.
And I think what people don't realize is we actually have access to the University of Maryland resources. So I'm interested in databases, and that's something that you do. That kind of software you wouldn't typically find in a normal hospital. But because of the University of Maryland and the fact that we actually pushed for access, I got all of the things I needed for my project.
Yeah, and unlike many institutions where we say like we're an affiliate of whatever institution, we're not like an affiliate by paper. I think we kind of talk about that. We truly are like 2 campuses, and whatever resources most of our attendings come down to Midtown. Some of them are the same that we have at downtown.
That's a good point of distinction, because I think when we interview candidates, we often get that question of what is the relationship? So just for clarity, I know we're at time. What we call University of Maryland Medical Center, officially that name, we refer to the downtown campus and this Midtown campus. And in the past, I don't know, almost 10 years or so, I think the faculty has become integrated to the point where each of the specialties, including my hospitalist in the Division of Medicine and subspecialties, are operating with the same faculty group of physicians at both campuses, which I think allows us to care for practically what that translates to for those of us who train here, practice here, is I think we have a more sophisticated cohort of patients or complex cohort of patients than most community medical centers with our footprint. Because the faculty being the same at both campuses, as you guys may know, at tertiary medical centers, capacity is usually the issue. And our downtown campus is often operating at or near capacity all the time. And it allows us to bring patients in from around the state and around the area to have access to the physicians in a way that they might not be able to if they were waiting for an extended period of time for a bed at our downtown campus. So we see Midtown receiving a lot more transfer volume from outside in the past handful of years, I think.
Awesome. I think that's an amazing reflection. You know, you have shared all the details about how your program is unique and how it, you know, kind of prepares you as the master clinician or kind of competent physician. And maybe before we sign up, I can't forget Dr. Ravi Singh. You know, he is our beloved team member. And as Dr. Chow knows that he is actually from the Sinai Hospital of Baltimore, and he is a regular member of CP Solvers. So maybe Dr. Singh, you want to say hi to them and then we can sign off.
Oh yeah, definitely. I'm really happy that you guys have come on and are showcasing your program. And I know Dr. Dobin Chow for many years. He mentored me when I was one of the chief residents. We have a great Maryland ACP chapter, and he was running Chief Residents Association in Baltimore back in the day. So I've worked under him, and we have a great Maryland ACP chapter, and Dr. Sood is working with me for the welfare and well-being of all IMGs. So we have an IMG committee that's looking after a lot of IMG concerns within all the programs in Baltimore. So I just want to congratulate you guys for the program that you're bringing on today, and really happy to see you guys, and hopefully see you in the meetings next year in person.
Hey, well, thank you so much. And it is because of Dr. Ravi Singh that we are with you today. He has added wonderful energy to our ACP IMG committee. And it was a wonderful opportunity that he afforded us by inviting us to be with you today. So thank you for thinking of us and including us and giving us your time.
Sure. So thanks again for joining us. I mean, if you are joining us on Saturday for 1 hour and even more than 1 hour, and you are sharing all your thoughts in a free-flowed manner, we appreciate it more than anything else. So thank you again for joining us, and we look forward to have you again, maybe in the future. And have a great day. Have a nice weekend.
Take care, everyone.
Thank you.